Well, hello. This is lecture for chapter 15 in your patient care, which is titled Vital Signs, Oxygen, Chest Tubes, and Lines. Quite a bit of information in this chapter. If you look at the key terms on 165 and 166, I would honestly tell you that we need to be mindful and aware of all of those terms, not necessarily regurgitating their definition, but understanding what they are, what they mean, and how you could break them down to figure that out. These terms are all typically having to do with vital signs and abnormal conditions of your vital signs, like when something is elevated or when something is too low. So these are all important for us to be mindful of with regard to patients. And we don't typically take vital signs, but it's not outside of our scope of practice to be able to. Sometimes if you're trying to help out, or you might work in an area where vital signs are important and part of the history of a patient, and it is possible that we are called to do that. Oxygen, chest tubes, and lines are all things that we either take radiographs for, or we have to deal with when we are taking images of a patient. So being mindful of the different types of equipment and what it does is also definitely within our scope of practice. So let's get started with this chapter. When we talk about patient homeostasis, homeostasis is basically the body's steady state maintained by adaptive responses that promote healthy survival. And it's monitored by physiologic feedback loops. And those feedback mechanisms can be two types. They're either negative or positive feedback loops. The body's feedback processes are predominantly negative, okay? And that is all found on page 166. You probably learned that in anatomy. So when we talk about the mechanisms for homeostasis, we typically reference the heartbeat, your blood pressure, body temperature, respiratory rate, and your electrolyte balance, which is very important and sometimes overlooked. As far as vital signs, on page 167, they start speaking about the measurement of vital signs. And when we take vital signs, you typically are taking a patient's body temperature, their pulse rate, their blood pressure, respiratory rate, mental state, and sensorium. At least making note of their mental state, how they're interacting with you. Are they mindful and present, aware of the day, the time, the place, where they are? And vital signs is an objective, non-invasive, and quick. Now remember, vital signs is objective information, meaning it's perceivable to your senses. All right. Subjective means that only the patient can perceive it. So when you're taking a body temp, you're looking at the thermometer. When you're taking the pulse rate, you're feeling the pulse and counting the beats. When you're taking a blood pressure, you're probably manipulating the sphygmomanometer and the stethoscope. So these are all things that are perceivable to your senses. When we look at temperature, normal body temp is average 97.7 to 99.5. Typically, when we think of body temperature, we usually reference normal as 98.6. So anything from 99.7 to 99.5 is considered within the normal range, because some people run up to a degree cooler, some people can run a degree warmer. It's just whatever is normal for you. That's the range, is typically 98.6 with about a degree either way. Respirations, typical average adult respiratory rate is 12 to 20 breaths per minute. For pulse, on an adult, average is 60 to 100 beats per minute. In a child, because they have a smaller heart and smaller organs, it beats more rapidly, so it beats 70 to 120 beats per minute. Same thing with a child's respiratory rate. Children's respiratory rate is typically 20 to 30 breaths per minute because their lungs are smaller and smaller capacity. Blood pressure, to be safe, the high side, when you start to get above 120 over 80, you are considered borderline hypertensive. That didn't used to be the case. The numbers used to be a little bit higher, but hypertension is a leading cause of deaths in the United States. It's called the silent killer. We'll talk about that because not too many people know that they have that issue, and there are no real signs or symptoms of high blood pressure other than taking it and knowing that it's elevated consistently. So 120/80 or lower is suggested for normal blood pressure on an adult. If we break these down one by one, when we look at body temperature, you're measuring the degree of heat of the deep tissues in the human body. And typically 98.6, like we said, is our average, and it's plus or minus 1 to 2 degrees Fahrenheit. The hypothalamus plays a role in preservation of the heat. When we shiver, that's what you're doing, is trying to preserve heat, and regulating heat loss, which when they reference diaphoresis is profuse sweating. So when you are warm, you tend to sweat. When you are cold, you tend to shiver. And both of those are your body's way of trying to regulate your body temperature. The routes of measurement for the body temperature, you could take an oral method, which is in the mouth, axillary, which is in the armpit, tympanic, which means you're using the tympanic membrane, which is in the ear, the temporal artery, which is what they're showing here, where they're swiping the thermometer across the temporal artery, and rectal thermometer. You can take a rectal temp, which actually is the most accurate body temp, is a rectal temp. So again, oral, axillary, tympanic, temporal, and rectal are the proper terms. You don't want to say you can take a temperature, mouth, armpit, ear, head, or rear end. You typically want to reference that those are the correct anatomical routes of body temperature measurement. And like I said, rectal is the most accurate when you're doing that. If we talk about as far as how quickly they're taken, oral temp is typically done on cooperative adults and children. The thermometer is placed under the tongue and an accurate reading is given. The tympanic is the quickest. It probably takes about 3 seconds, but it also can be very inaccurate if the nurse or whoever is taking the vital signs does not get an accurate seal on the thermometer in the ear canal. Temporal is non-invasive. It simply swipes across the forehead. And then rectal takes usually 3 to 5 minutes, and the thermometer is lubricated and placed in the rectum and then read after a few minutes. I was going to tell you though, the axillary is often referenced as useless because it takes so long. It typically takes between 5 to 10 minutes. And then with the axillary temperature, you typically have to add a degree to that temperature to read core body temperature. But it works really well if you have a non-cooperative child or a child that really just doesn't want their temperature taken. You can put that thermometer under their armpit and just kind of hold their arm against their body and let them sit there and watch TV, and it works pretty well. But again, we're talking about in the field. We're not really talking about home use. Not that you couldn't do these measurements in the home, but we're talking about dealing with patients in the clinical setting. After we take body temperature, the next one we will look at is pulse rate. The pulse rate is an assessment of the heart as reflected in the arterial walls throughout the body. The cardiovascular system is a closed loop system of vessels. And in this picture here, they are actually measuring the carotid artery pulse. If I go back for just 1 minute, just to mention the abnormalities with regard to the body temperature. With body temperature, if you look at the abnormalities, those are listed on page 168. If a patient has an elevated body temp, if it is above 99.5, then they have a fever and they are considered febrile. They also might be considered to be hyperthermic or have hyperthermia, which is an increased body temp. If it went the opposite way and their body temp was low, they could be listed as hypothermic, which has some significant attributes on its own typically when a patient is febrile, it's common with viral infections and bacterial infections, and it's a natural response of the body to increase their cellular activity to combat the invading organisms. So when a baby gets a fever, it's actually a good thing because the body is fighting something off. Okay, and the opposite of hyperthermia would be hypo, or a low body temperature. And that can happen sometimes when you hear about people being exposed to the cold for long periods of time. They get hypothermic, things start to slow down, their body functions slow down, which can be kind of a good thing because it helps preserve body function, and they can usually warm the patient back up if they get to them in time. All right, so back to the pulse. Again, assessing the heart as reflected in the arterial walls throughout the body. When we look at the physiology of the pulse, when the left ventricle contracts, blood is pumped out of the heart into the aorta and out into the arteries of the body. And the ventricular contraction is transferred to the arterial walls and permits pulse measurement. That's where you actually feel the pulse in certain areas on the patient's body. And some common sites where we measure the pulse, the radial artery, which is found by the radius in the wrist or thumb side, the brachial artery, which is in the antecubital fossa of infants, right in the little bend in their elbow is where you would find the brachial artery, and the carotid artery, which was the picture that they were just showing us where they're measuring that in the neck. When we look at pulse rates, you typically want to count the pulse for a minute, a full minute. A lot of people don't do that. They will count it for 30 seconds and multiply it by 2, or possibly they'll count it for 15 seconds and multiply it by 4. But the true accurate way would be to literally count it for 60 seconds. On an adult, average pulse rate is 60 to 100 beats per minute, or BPM. If they have tachycardia, meaning a rapid heart rate, that is when their pulse exceeds 100 beats per minute. And the opposite, if they have a really slow pulse, it would be considered bradycardia, and that is where the heartbeat is less than 60 beats per minute. And that, sometimes you find that in really fit athletes, people that work out a lot. So that's not always a bad finding to have bradycardia. As long as it's from you working out and being physically fit, then that's a good thing. The pulse rate on children, like we said, they have a smaller heart. It has to pump more efficiently. So their pulse rate is a little bit higher, where it's 70 to 120 beats per minute. Pulses are taken at rest. Okay, you don't really want to come running in from outside and then take a patient's pulse, or you don't want to just have walked them quite a distance from the emergency room up to the department and then take their pulse, or you don't want them to have been running in from outside because they're late for their appointment and then take their pulse. You want to make sure you're taking their pulse when they are at rest so that it's accurate. This is showing you that pulse rates and waveforms can be displayed on a cardiac monitor, so it's not always physically taken by feeling the patient's pulse. When we do pulse measurements, typically during CPR, the pulse is measured at the carotid artery in the neck, just because it's typically the strongest there and it's easier to assess there with the event going on as far as trying to rehabilitate that patient. In critical care settings, pulse rates can be measured with a pulse oximeter, which is found on page 171. That figure 15.7, you can see where they put that little, almost like a little clothespin on your finger, and it'll measure your pulse rate with that pulse oximeter. And you also can do the pulse rate by listening to the heart through a stethoscope over the left side of the chest, and that is called an apical pulse, where you literally listen and count the heartbeats through a stethoscope. And when you're listening like that, it is called auscultation. Okay, and the pulse that you're taking over the heart like that and counting is an apical pulse. And again, that information about pulse is found on page 170. As far as the pulse oximeters, a lot of patients you encounter will be wearing these. For infants, it's a light emitting probe, and it's typically placed on a big toe. Sometimes on infants too, I've seen them put it on a baby's head. It can be attached to the earlobe, the temple, the nose, or the foot, and that's for adults as well. So if patients don't have it on their finger, typically that can be because they have artificial nails or nail polish, or maybe they don't have fingers, but you can put it on toes, earlobes, temples, the nose, or the foot. And the oximeter converts the light intensity into oxygen saturation and pulse rate values. And normal pulse oximeter values for a healthy person would be, as far as saturation levels, 95 to 100%. And honestly, 95 is a little bit low. It should be, Tom is a respiratory therapist. He would argue that it should be 97 to 100, but 95 is awfully low by respiratory considerations. When we look at respirations, this is probably the most challenging to take because when you're watching a patient breathe, it's a little bit creepy to stare at them and watch them breathe. Respiration is a rhythmic exchange of gases through the lungs. During inspiration, the diaphragmatic muscles, when you breathe in, your diaphragm moves down and it pushes the abdominal contents outward and expands the chest cavity. Okay. When you allow relaxation and the air rushes into the lungs because of a slightly lower pressure in the lungs compared to the atmospheric pressure. When you exhale or expiration, that occurs when the lung pressure is greater than the outside atmospheric pressure. When you're assessing respiratory rates, the tidal volume is the amount of air exchanged under normal conditions, and it's measured as the number of breaths per minute. Okay, so if a patient, an average respiratory rate is 12 to 20 breaths per minute. If they are breathing more than 20 times a minute, then they are considered tachypnic. That Tachypnea is tachypnea. Tachypnea is where they are breathing greater than 20 times per minute. If they are breathing less than 12 times per minute, then they would be experiencing bradypnea. Okay, and bradypnea describes a decrease in the respiratory rate. That tends to occur much less frequently than tachypnea. Typically, if they have bradypnea, where it's slowed rates, that comes from depression of the respiratory center of the brain. So it's common with drug overdoses, head trauma, and hypothermia. In order to have an accurate measurement, you should be assessing the patient's respiratory rate, the respiratory depth, and the pattern of the respirations. Again, taking respiratory rates without the patient's knowledge is probably key so that you get an accurate reading. Blood pressure measurement, this is on page 171. All right, and when you're measuring blood pressure, you're actually measuring the force exerted on the walls of the arteries during cardiac contraction and relaxation. So there's two values with a blood pressure. There is a diastolic number and a systolic number. And it requires two pieces of equipment to take a blood pressure. That is a sphygmomanometer and a stethoscope. Okay, so your systolic pressure, the systolic pressure is the peak pressure during contraction of the heart, and the diastolic pressure is the pressure at rest. So systolic is caused by pressure no longer exceeding the internal pressure or contracting. Diastolic pressure occurs when the sound of blood flowing through the arm can no longer be heard, where it's relaxing. It's usually less than 80 millimeters of mercury is normal, and with the systolic, as long as it's less than 120 millimeters of mercury, that would be considered normal. So 120, it's always written as systolic over diastolic. Less than 120 over 80 is desirable. When you're measuring blood pressure, you typically measure over the brachial artery in the arm, and you inflate the cuff to exceed the systolic pressure in the artery. You actually want to collapse the artery with the inflatable cuff so that you can hear the blood rush back through. You release the air in the cuff until the pressure in the cuff matches your systolic or the patient's systolic pressure. And when no sounds are heard anymore, the diastolic pressure value has been reached. I will tell you, even though you can see this aneroid style sphygmomanometer that they used to use all the time, most often now in field, they're usually using the blood pressure monitors where this wraps around the patient's arm, but it gives an automatic readout. Manual blood pressures, if they're done right, they're very accurate, but typically because of the inconsistencies in the way people take them, typically it is an electronic out now and not a manual. The systolic number, like I said, is always written over diastolic, so 120/80 is normal in a healthy person. Ideally, you want that or lower. If they have hypotension, then they are below normal. Again, that is not necessarily a bad thing to have low blood pressure unless it's so low that you're actually passing out. And hypertension would be greater, consistently running greater than probably 120/80 is the high side of normal. Most of the time, they will call you borderline hypertensive if you're around there. If you exceed typically 140/90, then you are termed hypertensive. It's often referred to, like I said before, as the silent killer because a patient is typically asymptomatic, meaning they really don't have any symptoms until the damage has been done and it is too late. Next, we'll move into oxygen therapy. Oxygen is absolutely essential for all life processes. Oxygen is a colorless, tasteless, odorless gas that plays a critical role in the efficient cellular metabolism. It makes up 21% of the atmospheric gas. It's not flammable, but it supports combustion, and it absolutely is considered a drug. So it has to be ordered by a physician. Now, usually that's an interesting fact because I'm sure you've all heard of, seen, or been to an oxygen bar. And I always wondered how they can actually operate because a physician is not prescribing that. But when I looked it up, typically it's because the FDA is not going to go after them for running those. But could they? Absolutely, because those oxygen bars should not be in business if there is not a physician to order it. So it's actually a drug that must be ordered or prescribed by a physician. Primary clinical indications for oxygen administration are to correct hypoxemia and possible tissue hypoxia, where there is not enough oxygen in the system or in the body. And if you think about it, if oxygen makes up 21% of the atmospheric gas, it's kind of interesting. And I don't know if you've ever wondered, why does CPR work when we used to breathe for the patient? I could never understand how us blowing out carbon dioxide would actually work for the patient in helping them to breathe. But if oxygen is 21% of the atmospheric gas, and we only use, when we breathe, about 4% of that, which means that if you're inhaling 21% and you're utilizing 4%, then when you blow out, you're typically releasing approximately 17% oxygen, which means that it would be very effective by blowing your exhalation into a patient that was not breathing, because that would provide sufficient oxygen for them to have circulate through the body when someone is compressing the chest. Now, the reason we don't really breathe for the patient, because they found that the amount of air that's left in the lungs typically has enough oxygen that if the compressions are done adequately, then there is sufficient oxygen to circulate through the body. When we look at some oxygen devices, these are on page 173. This is a large liquid oxygen supply, and then you might have seen patients like in grocery stores or out in public where they have these small portable liquid oxygen canisters. Typically, the way we see them in the hospital is the portable devices, like this portable oxygen cylinder. They can be continuous flow, conserving device systems. And notice that green is the universal color for oxygen. Okay. When we look at the delivery system, oxygen devices are designed to operate at a certain number of liters per minute. And you want to make sure that you know how much oxygen a patient is on before you disconnect them. Because if you're going to connect them to, let's say, room oxygen in the department, and you shut off their tank before you know the number, you won't know what to put them on in the department. So very vital. I think we've all done it at least once where you shut it off and then you realize, oh my goodness, I don't know what they were on. Sometimes the patient will know what they're on, sometimes they won't. So then you've got to call up to the floor or wherever you got them and figure that out so you can supply them with the oxygen. This oxygen flow meter right here is green in color, or it has green labeling, and typically has the word oxygen very clearly written on it. This little Christmas tree adapter, the tubing hooks onto that, and then you turn this little flow meter, and you can see this little tiny silver ball in here, and when the oxygen is on, that ball raises to the number of liters per minute that you are allowing to come out of the wall and go into the patient through the tubing. As far as portable oxygen, it's important, again, to check the system before you transport a patient to make sure that there's an adequate oxygen supply available throughout the transport period and during the radiographic procedure. In our rooms, we always have wall oxygen, so that is not an issue. The issue would be getting the patient from wherever you're taking them to the department, making sure you have adequate supply of oxygen there. As far as oxygen delivery systems, we are not going to go heavy into this. I just want you to realize that with oxygen delivery systems, there are either low flow rates or high flow rates. And typically low flow and high flow, the main difference is if it's a low flow device, it does not meet the entire inspiratory needs of the patient, meaning it's just an aid. It helps the patient breathe, but they don't rely solely on that. They actually breathe on their own as well. Whereas a high flow device is typically meets or exceeds the inspiratory needs of the patient when the device is functioning properly. So they're not really breathing on their own. The device is supplying all of their oxygen. That's the main difference. The nasal cannula is the most common device used to deliver low flow oxygen. The nasal cannula is actually on this next page, so I'll show you that. But there are also masks, tents, oxy hoods, and ventilators that deliver oxygen. So this picture up on top is a nasal cannula. You will often find patients in the hospital with those on. They're comfortable because it goes over the ears. The little tubes go up into the nose. Patient can talk, eat, drink without issue. When they start wearing these masks, then it's kind of a pain because they're hot, they can't be understood, they're kind of loud, and so the patient has a hard time hearing. And I do not need you to know all the different types of masks. Just know that patients have different masks, and they do different things from a respiratory therapy standpoint. The Oxy tent are not used anymore. What it used to be, literally, they would kind of make a tent over the pediatric patient's bed and kind of fill the whole thing with oxygen so that they were in an oxygen tent. But what happened with that is a lot of those patients would end up with pneumonia because they would have moist oxygen, and they would be contained in a little tent with that. So they don't do that anymore, but these oxy hoods, like you see here, those you might find in a NICU or in a pediatric unit where this is just, the baby's head is in there. It's not It looks barbaric, kind of like that, but what it is the oxygen is delivered in here so that the baby has a constant supply, because you're not likely to get a mask on a baby. Not going to have them stay with a mask on their face, so these oxy hoods serve that purpose. Ventilators, I will show you in just 1 minute. Actually, I don't know that I have a slide. If you look, a ventilator is actually found on page 178, figure 15.23. That patient is on a ventilator. And I'll tell you about that in just 1 second. But I want you to realize that if a flow rate, if a patient is on a rate of higher or greater than 4 liters per minute, then you have to add humidity to the oxygen flow to prevent mucosal drying, because oxygen is very, very dry. So they have this little thing here where the oxygen will come out, go through a water system, and then into the tubing and into the patient. Now, that's not something that we set up or do. You just have to realize if they're on more than 4 liters per minute, they will have humidified air. As far as the ventilators, the only thing I wanted to tell you is don't ever, if you go in a patient's room and they're on a ventilator, do not ever silence the alarms. Don't ever push any buttons on that. Don't dislodge anything. Pretty much just don't touch a patient on a ventilator until a nurse is there or respiratory therapist is there to assist, because you don't want to be responsible for doing any damage or dislodging any lines when a patient's on a ventilator, because that is literally doing all their breathing for them. Some considerations that we have to be mindful of: under no circumstances should an oxygen device be completely removed from a patient just for the purpose of taking a radiograph without the consent or supervision of either a physician, a respiratory therapist, or an attending nurse. Okay. Then we move into chest tubes and lines on page 178. And I'm going to tell you that collectively, anytime we are doing imaging for tubes or line placement, we always are going to be asked to take a line placement confirmation radiograph. Meaning, once a physician or respiratory or someone places a line, they're going to ask for radiographic confirmation that that line is in the proper place. Now, how does that work? Typically, these lines and tubes have a very thin piece of metal that outlines the placement area so that it can be visualized on a radiograph. Okay? So we're going to talk about some endotracheal tubes. Remember, endo means within. So in the trachea, that's an ET tube. Chest tubes is the lay term. Typically, or technically, they're called thoracostomy tubes. We're going to barely touch on central venous lines and pulmonary artery lines. But ET tubes, chest tubes, we definitely have to image for placement on those. An endotracheal tube or an ET tube is on page 178, and they are typically used to manage different respiratory complications. Okay, the placement is a hollow tube in the tracheal lumen, or the opening of the trachea. Typically, it's inserted through the translaryngeal approach, commonly called intubating a patient or intubation method. The tip of the tube is placed just above the carina, typically 1 to 2 inches above the carina, or 3 to 5 centimeters above the bifurcation. Now, what are they talking about? The area where the trachea bifurcates or splits into two, it splits into the right and left main stem bronchi. That is called your carina. Okay, where the trachea bifurcates or splits in two is called the carina. So you want this endotracheal tube should be 1 to 2 inches above that area, so that when ventilation is applied, it will actually inflate both lungs, because the tube is above the area where the trachea splits into two to go into the right and left main bronchus. Chest radiographs are absolutely required to verify position, and the most common malpositioning or bad positioning happens when the tip ends up in the right mainstem bronchus due to the angle of the carina, meaning the way that the trachea bifurcates. Typically, if the line is going to go where it shouldn't, it'll slip into the right mainstem bronchus, which means that you would, when they typically call it bagging a patient. If you've ever seen on the ER shows and things like that, where they have that typically like a blue big fat balloon and they're squeezing it and breathing for the patient. Typically when they're doing that, that is when they have an ET tube. Indications, different indications for respiratory issues, all of those listed there. They might need mechanical ventilation, they're not having sufficient ventilation, parenchymal disease that impairs gas exchange, an upper airway obstruction. They might be going into shock, impending gastric acid reflux, or they've aspirated something. If they're going to do what's called a tracheobronchial lavage, or where they wash the bronchioles, they wash the lungs, basically. They do a lung wash to get fluid back, and they test that to see what's going on with the patient, if they have something rare going on that they're having a hard time diagnosing, or just to confirm that it's pneumonia, things like that. Anytime a patient has an ET tube, there is an absolute requirement for a radiograph to confirm position and placement of that tube. This is what an endotracheal tube looks like. Again, it's on page 179. And this is just showing a portable chest demonstrating the proper ET tube placement. It is probably very hard for you to see. They've circled it. You can kind of see the line coming right here. It comes down, and the end of it, which I'm not sure why they wouldn't mark the end of it, is right about here. Okay, so that is a portable x-ray. Not a bad picture, it's not the greatest picture, but when it's portable like that, it's usually because the patient's sick. You can see the EKG leads on the patient coming across all these lines. It's hard to tell. I don't see an oxygen line, but definitely EKG or ECG leads on the patient. After we talk about ET tubes, now we will go into another common tube that we see, which is called a thoracostomy tube. A thoracostomy tube is the technical term. Most of the time you will hear them referred to as chest tubes. The purpose of a thoracostomy tube is to drain the intrapleural space and mediastinum. It drains it of any fluid or air that might be present. It can create negative pressure. It helps relieve atelectasis, which is a collapsed lung. Okay, so what happens is when the lung collapses, so let's try and draw this on here. All right, let's say, don't laugh at my drawing. Let's say this is a normal, this is your normal left lung, okay, with the little notch for the cardiac. That would be a fully inflated left lung. So this will just mark N for normal. Let's say up here, you have your lung, and part of that lung is collapsed, like where it should be. This part in here has collapsed. Let me get my little pointer. So if this part in here has collapsed, okay, then that means that portion of the lung is no longer inflated. It's collapsed. The area that's collapsed is called, the patient suffering from atelectasis, which is a collapsed lung. Now, what fills in that space determines whether they have a pneumothorax, a hemothorax, pleural effusion, or empyema. All right, so the lung collapses, that's atelectasis. If air fills that space, it's called a pneumothorax. If blood fills in that space, like let's say they got stabbed, that might be that they're suffering from a hemothorax. If there's pleural fluid in that space, then that's pleural effusion. And this one is kind of gross, but if there's pus in that space, then they're suffering from empyema. So atelectasis is the condition of having a collapsed lung, and then what fills where it's collapsed determines which of these the patient has. So when that collapses, they have to insert a chest tube. And when they insert that chest tube, they insert it into that area, drain out whatever's in there so that it goes back to a fully inflated lung. Okay? These are not comfortable for the patient. They're typically put in trauma situations. There's no warning. There's no numbing of the patient. They're typically placed between the 5th and 6th intercostal space, so between the 5th and 6th rib. The insertion sites vary with the intrapleural substances to be removed. So if they have a hemothorax or a pneumothorax or pleural effusion, depending on how severe it is, will determine where they actually insert that tube. But the point is, when they insert that tube, whatever's in there will come out. Like literally, if you're standing in there and they put in a chest tube and it's full of air, you will hear psh when the tube goes in. If there's blood in there, get out of the way, because as soon as that tube goes in, that blood will come out the tube. What it does is, atelectasis is when the lung collapses. When you put that thoracostomy tube in, you're reestablishing the negative intrapleural pressure so that the lung can reinflate. So whatever is in there is going to come forcefully out of there. All right? All right, and notice it says typically it's 5th to 6th, but it can be as high as the 4th intercostal or in between the ribs space, or as low as the 8th intercostal space. When a patient has a thoracostomy tube, there absolutely is confirmation with a radiograph of line placement. And this picture says that the thoracotomy tube is inserted in the left lung to decompress a pneumothorax. Okay, so this is the left lung. You can kind of see the tubing up in here. And that patient has the tubing because this lung is not fully inflated. You see how this lung is fully inflated? You've got the costophrenic angle, cardiophrenic angle. You can see the hilar markings. This is a fully inflated lung. This is the right hemidiaphragm. But the left hemidiaphragm, you really can't make out. There really is no, you don't see the left, or I'm sorry, costophrenic angle, because this lung is not fully inflated. They mention an important point that follow-up chest radiographs should be taken with the patient upright or semi-erect to better demonstrate a pneumothorax. Why? Because air rises. You can also do what are called inspiration-expiration chest x-rays, and you have to be very, very careful not to dislodge the chest tube or the thoracostomy tube. Patients are extremely sensitive about their thoracostomy tube. It's about the size of a garden hose sticking out of your chest, if you can imagine that. So not comfortable at all. Patients don't want you to touch it. They don't want you to bump it. They don't want you to move them. They really are very protective of their thoracostomy tube, rightly so. PICC lines. PICC lines are actually found, if you look on page 182, it stands for a peripherally inserted central catheter, but we usually just call them a PICC line. We also do confirmation of line placement when they insert PICC lines. When they do this, notice it says that the catheter tip is placed in a large central vein. The ideal position is the superior vena cava. Other sites, though, could be the subclavian vein, so sub meaning below the clavicle. So subclavian vein, internal jugular vein, the femoral vein, and radiographs are definitely taken to confirm line tip placement. right? So we have a huge responsibility in that we are oftentimes taking the images to confirm that the lines and tubes are in the right place. Now, we've talked that diagnosing or reading or interpreting an image is absolutely outside our scope of practice. But hear me out when I finish this, when I tell you this. Even though we don't diagnose and we don't interpret, we typically look at enough chest x-rays that we can recognize when a line or a tube is malpositioned or not in the correct place. So we don't read the image, we don't interpret the image, but what we do is we can recognize that malposition and we can actually inform the person that's responsible that placed it or the radiologist. We need to let them know that it is in the wrong place so that something can be done for that. Okay, so radiographic confirmation of line placement is essential at the time of insertion and thereafter as needed. And recognition of that catheter malposition requires thorough knowledge of the CV structures and their branches. So that's talking specifically about a PICC line. But what I'm telling you is that with any line or any tube, notice it says with any expectation of the radiographer, or without any expectation of the radiographer to interpret image from a pathologic diagnostic standpoint, when malpositioning is thought to have occurred, alerting the appropriate authority, whether it's the radiologist, the attending physician, respiratory therapist, whoever placed it, not only appropriate, but it's beneficial to the patient because you're not diagnosing anything. You're simply saying that I've done this long enough to know where the line should be, and the line is not where it should be. So I'm letting you know so that you can do something about it, because the only one that truly suffers in that situation is the patient. Does that make sense? The patient suffers because their line is not in the correct place, and if that's the case, then they're going to suffer. So you alerting someone is vital, and that is within your scope of practice. You are allowed to pass that information along. Okay. In conclusion, when we talk about vital signs, that vital sign assessment is a critical part of emergency patient care, and it is within the scope of practice for a radiologic science professional. So we don't take vital signs all the time, but it is not unrealistic to think that we could potentially take those vital signs. When we assess vital signs, it's an objective, non-invasive evaluation of the patient's immediate condition or their response to therapy. And the accuracy of the data collection and the recording is critical. That information is used to diagnose a patient. It is used to record what's going on at the time the patient was seen. So making sure you're not only taking the vital signs appropriately, but that you're taking them accurately is important. When they talked about oxygen, the need for oxygen becomes critical to patients when the internal environment of the body is not consistent. Oxygen is not something we can do without. Patient ventilators require special care and handling, and the technologist must never alter ventilator alarms or settings, and oxygen flow should never be interrupted in order to perform an exam without the consent of the physician, respiratory therapist, or the nurse. As radiographers, we have to understand the use and appearance of common chest tubes and lines, including ET tubes, thoracostomy tubes, and central lines. So we have to be very, very mindful of where those are and inform whoever needs to know if the malpositioning has occurred. If it is not where it properly should be, it is your duty as a technologist and to that patient to let someone know so that something can be done to correct that. Okay? I do not have a questions, comments, or concerns slide, but even though I don't have the slide, it doesn't mean that they're not warranted. So if you do have any questions or comments or concerns, please make sure you noted them on the slide. When we next meet, we will discuss that, and I will help clear that up for you. Again, make sure you're looking at the glossary terms or the key terms at the beginning of the chapter. These are actually found on page 165 and 166. All the terms are important to us as technologists. We need to be mindful of those terms as well as vital signs and our tubes and lines. And thank you very much. And when we meet up, I will help answer any questions or clear some things up for you.